It's working all fine?
Yes, it is.
Great. All right, so hello everyone. My name is BRODERICK MCCALLUM HEE, and this is my final master's presentation into my research on the dosimetric impact of the mechanical movements of the Linac Gantry during treatments with small fields. And my supervisors for this project were Pejman and Tom. In this presentation, here's a brief overview of what I'll be covering. Before I'd like to actually get into the depths of my project, I'd like to provide a nice contextual background into the progression of conformal techniques. So I've drawn up a sketch diagram here where on the x-axis we have the progression of time, and this also corresponds with improvements in our treatment planning systems and machines. In particular, the MLC technology improvements are of note. On the y-axis, roughly speaking, this corresponds to increases in accuracy, complexity, and conformity. So the first technique I'd like to note is static IMRT, and this refers to intensely modulated radiotherapy. And to explain how this works, there's a few key concepts in treatment planning I'd like to highlight. So during treatment planning, the first thing we do is delineate the gross tumour volume. And the additional margins have to be added to this because we're not exactly certain where there is subclinical potential clonogenic tumour cells. So in addition to the gross tumour volume, the GTV, we then also delineate a clinical target volume, which encompasses all potential tumour cells. An additional margin is then added to account for any variations in patient setup or any other errors which could occur in treatment. And that gives us finally the PTV. And this is the planning target volume and is where we aim to deliver radiation during external beam radiotherapy. Now, I've just drawn a theoretical delivered dose, which corresponds to that which could be delivered by static IMRT. And as you can see, it's generally quite conformal. However, there's still a tiny bit of healthy dose delivered outside of the target volumes. In this picture, I should note that it's slightly exaggerated just for the sake of demonstration. So following the development of static IMRT, we then moved into dynamic IMRT. And in this technique, we used MLC movement to enable more conformal dose delivery and deliver even tighter constraints to the target volumes. Following this, in addition to moving the MLC, we also decided to move the gantry while treating, and this was in VMAT. And again, we see a further increase in conformity. And as a side note, in the progression of these techniques, we also saw an increase in the use of image-guided radiotherapy. And this allowed us to be more certain of our target volumes and decrease those margins as well. The final technique I'd like to highlight are stereotactic techniques such as SABRE and SBRT. And these are very highly sophisticated techniques which are approaches to deliver conformal doses and very high doses to the target volumes. So what we see in this trend here is an increase in the use of small field radiotherapy techniques. And in particular, just as a general context, a small field is generally a field that's under around 3 by 3 centimeters. And we're seeing this increase as we're selecting smaller PTVs and using smaller beamlets to deliver heterogeneous doses. And to deliver these techniques, the main machine we're using is the medical Linac. And here on the right, we just have a picture of a standard Linac, which you may find in the clinic. Now, there are many different potential sources of error during treatment, coming from things such as patient positioning, organ motion, couch movement, MLC movement, all the things listed here. But in particular, in this project, we really wanted to focus on the impacts of Gantry Sag. So, as I mentioned, a key mechanical error source is Gantry Sag. And here on the right is a rough diagram for different angles, the cross-plane and in-plane Gantry Sag measured in previous study. So the gantry head weighs a lot. It weighs several tons from all the different components in there, the shielding, the beam generation, the shaping systems. There are a lot of mechanical components, and this causes gravity to cause a quite wobble during treatment and just during gantry movement from an ideal circular path. And this corresponds to movement in the isocentre. It should also be noted again that there are also mechanical imperfections from other areas, such as misalignment of the components or aging of the machines. And one example is ball bearing deterioration. In terms of managing these errors, it's very important that we have good quality assurance practices. And this just refers to everything we do to make sure that our machines are delivering radiation accurately and how we want them to. And quality assurance practices vary depending on the centre. However, they are informed on recommendations from main bodies in the radiotherapy space and also in literature. So here I pulled out a few of the annual QA recommendations for the mechanical isocentre radius. So the first is 0.5 millimeters, just as a side note. This is the one used at Sir Charles Gardner Hospital. And this also happens to be the variant acceptance level. 1 millimeter from baseline is recommended by the AAPM in the task group reports 142 and 198. And as a side note, these reports here are one of the most prevalent references for QA program development. Subsequent literature from studies such as Denton et al. And Ramachan et al. Indicates that 1.5 millimeters absolute tolerance is the acceptable level for stereotactic and for VMAT treatments. And these levels all correspond with a 1 millimeter from baseline or a 1.5 millimeter absolute radius of the mechanical isocentre. But it's very important to note that all this literature, we still have limited data to support their use with small field treatments. And there's no report at all if tolerance has an impact on highly sophisticated methods, specifically stereotactic VMAT. There are two relevant studies of note for this project. The first is that done by Milan et al., and they evaluated the impact of isocentre shifts for VMAT. And they did this by using Electa Monaco treatment planning system, which uses Monte Carlo simulations, basically the gold standard we have for dose distribution calculations currently. However, using this TPS, they were restricted by a beam limit. So unfortunately, they had to discretize their plans, and that's introduced a slight error in their calculations. The conclusions of this study found that there were minimal reductions for less than 1 millimeter of isocentre shift in support of TG142. At the time, TG198 had not been published. They also suggested that future research should be done for stereotactic plans. There is only a single study found for stereotactic plans, and that is done by Wack et al. And they evaluated the impact for, as mentioned, static stereotactic plans. To do this, they used Phillips Pinnacle TPS, which is a collapsed cone convolution algorithm. And a limitation of this study is that this dose algorithm loses accuracy for smaller PTVs and high doses. Additionally, they only examined theoretical spherical targets and uniform shifts, and this may not correspond to the real-life behavior in a clinical situation. However, their conclusions suggest that the 1 millimeter threshold that we see prevalently in literature may be too large, and they recommended instead that we use a 0.5 millimeter threshold for the mechanical isocentre radius. So, this project thus aims to evaluate if the current tolerance level is acceptable for small field treatments, computationally evaluate the dosimetric effect of isocentre uncertainties caused by Linac Gantry movement, and to compare the dosimetry for when these isocentre uncertainties are accounted for and not. The significance of this, which I've highlighted through the literature explanation there, is that we're seeing an increased use of small fields, and that means it's very essential and that we need an effective quality assurance program. And to develop that, we need data so that we can inform our practices and make clinical decisions that will result in optimal patient outcomes. And finally, this project was in pioneering research of this field. So the methodology started with some Gantry Sag data provided from Rowshanfarzad et al. And this study, previously done, quantified Gantry Sag for Varian, Electa, and Siemens Linacs. And here we find a graph for different gantry angles on the x-axis and y-axis representing the Gantry Sag in the cross and in plane for Varian and Electa machines. In this project, we used the Electa data in a machine agnostic approach in a somewhat arbitrary selection. However, it was the smoothest pattern observed. This shouldn't have impacted results though, because we did find there were similar patterns for all the different manufacturers. And in addition, each individual Linac studied previously by Rowshanfarzad et al. Varied depending on its age, its type, its usage case scenario, and therefore a real-world Linac may not necessarily reflect the Gantry Sag patterns observed on average. And additionally, although there were slight differences in magnitude, the Sag magnitude was not relevant as the pattern was scaled during the processing of the data. So the impact of this Gantry Sag was modelled via isocentre modification. And to do this, planned dicoms were imported and modified in Matlab. And this enabled us to manipulate the dicoms in a very flexible format and use all the technology of Matlab before putting them into the very rigid dicom structure. As mentioned before, I applied various scaling factors to determine what different effects of Gantry Sag would have on the treatment plan outcome. And we used average shifts where they were magnified so that there was an equal value of magnitude to different literature tolerances and a few midpoints between them. So in this graph, we have the crossplane and in-plane sag again for various factors. The circles represent different tolerance levels found in literature, and the dark or the solid lines represent different Gantry Sag patterns which were applied in this study for different scaling factors. So 6 different scaling factors were considered. To apply these isocentre shifts to the plans proved to be the most challenging aspect of the project, and the TPS required a constant isocentre for every VMAT arc, and this proved problematic when processing things. And this was actually an issue encountered by Wank et al. When they started to look into stereotactic plans, and for them, they decided just to avoid VMAT and look at static plans instead. However, I managed to circumvent this by splitting each arc at every control point, and this resulted in modified plans with a series of small VMAT beamlets, which resulted in a pattern which overall represented the original plans. And to demonstrate this pictorially, I pulled out some of the 3D visualizations from this project that were conducted in variant eclipse. And here in these pictures, notably the blue beams represent setup beams, which were ignored. Although the setup and changes in the setup may have indirectly affected patient outcomes, it was considered sufficient to evaluate dosimetric impacts via just the treatment beams. The blue beams are setup, the yellow beams are treatment beams, and these red little markers and rectangles represent each of the control points. So for these 3 sites, after splitting, the plans looked like this. So as you can see, the number of beams dramatically increased as every single control point got its own beam. Another issue found in this process that made it even more difficult was that the TPS required a minimum of 3 control points from MLC movement. So we had to interpolate a 3rd point between each of these control points. To do this, a Matlab script was created, and a simplified structure of the script is shown on the right, but I won't be working through that line by line for the constraints of time. However, this script removed plan identifiers, and this enabled easier management of the plans and movement of them between different categorization folders in the TPS. It split the arcs, and it applied factors of isocentre shift from that previously shown graph. The creation of this script required extensive coding and manipulation of plan DICOM files. After splitting each of these plans, dose calculations were done in the variant eclipse TPS, specifically the toolbox version, which is the non-clinical duplicate of the software. We used the Accurus beam algorithm and version 16.1, and this uses a linear Boltzmann transport equation solver. And it has been shown that this type of dose algorithm produces highly accurate distributions similar to Monte Carlo simulation in faster times. Dose calculation grid of around 1.25 millimeters, well, of 1.25 millimeters was used, and this is well within the bounds of 2 millimeters, which is recommended by the ICRU for stereotactic treatments. Finally, with the dose calculations, different DVH information was extracted from the TPS to enable computation of DVH-derived plan quality metrics. Examine the plans via 6 clinically relevant metrics: the maximum dose relative to prescription isodose, PTV coverage, PTV dose near minimum, prescription dose spillage, gradient index, and conformity index. For those metrics where there is some variation in definition in literature, and depending on the source, you may have slightly different variants of the metric, I've highlighted where the definition that was used is from, and that was from the ICRU Report 91 and the UK SABRE Consortium. Additionally, I also considered PTV size and plan complexity in MU per gray for each of these metrics. For the project, 28 plans were examined, and for each plan, 8 different versions for the original, VMAT split, and for the different magnitudes of shift were calculated, resulting in 224 instances total. As you can see in this table, the majority of the plans were from the pelvic bone region, and this is because it was the main stereotactic site treated at Sir Charles Gardner Hospital with a Linac. The 3 brain plans at the top were originally from CyberKnife, however they were replanned in Eclipse. Results. So here this graph represents, on the x-axis, an increasing average radius of isocentre shift. On the y-axis, there's the percentage change observed for the maximum dose relative to prescription dose. Each of these dot points, or each of these grey circles, represents the raw data observed, and the box plots are shown in different colours. Squares represent the average and crosses represent the outliers. And this graph I'm going to present a few different times to some other metrics in this presentation, so that description applies to all the following graphs. And as you can see from here, there was no clear identifiable trend in the prescription isodose. However, that was somewhat expected, as it is just the ratio between the target and maximum dose in the PTV. However, the applied isocentre pattern did cause random variances, and this has to be taken note of. In a clinical situation, an increase in the dose is generally good for tumour control. However, if it becomes too large, we risk compromising aspects such as bone structure. Here, the plan complexity and shifts have been plotted in a column graph. Each colour represents a different average radius of isocentre shift. Each of the bins corresponds to different plan deliverability complexities, as mentioned before, in MU per grey, and again, the y-axis represents percentage change. And there I've chosen to show the PTV coverage and conformity index. Again, the plan complexity wasn't a very interesting metric. We found that plan deliverability complexity was not a key determinator of sensitivity to isocentre shifts in this range. And it should be noted that all the plans examined were stereotactic VMAT plans, which by their nature are already quite complex. And here this metric only had a range of 300 to 260 overall in the plans examined. We did, however, note that there was a slightly increase for the category of 300 plus, where they were slightly more affected. Here again, I used the same graphs as presented earlier. For PTV coverage, we saw a decrease with increasing radii of isocentre shift, and this corresponds to a plan deterioration. And similarly for the conformity index, we saw an increase, which for this metric also corresponds to a plan deterioration. So, as expected, the plan quality deteriorated with increasing numbers of isocentre shift. The PTV coverage and conformity index for 1 millimetre of average shift were found to change by 4 and 8%. And these numbers of 4 and 8% increased when we looked at the exact impact of PTV size. So this increased to 7% and 12%. And as you can see from this graph here, there's a clear correlation with smaller PTV size and plan sensitivity to isocentre shifts. And these graphs here are just for show, so they're quite small, but similar deterioration was observed and trends that were consistent for all the other metrics. And here is the PTV near minimum reported relative to the prescription dose spillage, and gradient index. To interpret these results, we looked to literature to find levels of what could be acceptable for change. The AAPM and ICRU recommend that doses delivered within 5% of that prescribed. Additionally, examination of UK Saviour Consortium recommendations, which are also used at Sir Charles Gardner Hospital, suggest that a 4% change is the threshold of acceptability. And notably, conformity index can be considered a combination of two metrics, so an 8% change was considered the threshold of change here. And the conformity index maps prescription spillage and also PTV coverage. So, based on these results and assumptions, we recommend that an absolute mechanical isocentre radius tolerance level of 0.5 millimeters with action of 0.75 millimeters for PTV sizes below 10 centimeters cubed is used. In terms of implementing this recommendation clinically, there are three options that I present here that could be done. The first, and potentially the most obvious, is to ensure and keep that the machine isocentre deviations within this proposed limit. And this is possible on modern linear accelerators. However, it may not be possible at some centres, especially if older machines are in use. A second approach is to explicitly account for machine deviations in the GTV-PTV margins that I mentioned at the start of my presentation. In some regions, such as the brain, where additional dose could cause necrosis, machine deviations in the GTV to PTV margin may not be able to be increased, and it may not be viable to adjust them. The third approach would be to directly quantify and correct for Linac-specific mechanical errors. And this has a number of advantages, however, may not be possible with the TPS used, and/or there may be insufficient staff time to collect the required data. However, as a note for option 3, previous study by Du et al. Indicates that a correction study could be used to reduce gantry sag to less than 0.2 millimeters. Additionally, a study by Wegner et al. Also demonstrates that such an approach is clinically viable for stereotactic plans. If none of these three options can be done, it's potentially possible that the machine is not suitable for stereotactic treatment. In these cases, other treatment approaches should be considered, such as non-stereotactic radiotherapy, where the fractionation and use of lower doses means that it may be more viable, or non-radiotherapy techniques such as chemotherapy should be considered. However, a few limitations of this study. And the first one is that 75% of the plans were for pelvic bone treatment sites, and bone being of high density means that the dosimetry may be slightly different to softer tissues in the body. However, analysis was conducted relative to distributions for a given plan, and the conclusions are not reliant on a particular site. Finally, the metrics reported did not consider the dose to and coverage of organs at risk. It should be noted that because of these stereotactic plans were using quite high doses, it was observed that the doses which were spilled and the doses in general being delivered to healthy tissue were close to some of the limits for organs at risk. Therefore, for organs at risk close to the PTV, again, brain as an example, even tighter tolerances may be required. And so future work could consider more aspects of plan quality and treatment sites to further validate these conclusions. And here is a very brief traffic light conclusion summary of the isocentre radius limits that were found in this study. The red ones represent levels that if you find this isocentre radius, your machine may not be suitable for stereotactic radiotherapy and action should definitely be taken. The yellow levels correspond to action levels, which the yellow 1 millimeter is that recommended by AAPM. And above this level, you should take action. For these green levels, you can be reasonably confident in the dose accuracy. However, it's still very important that you check organ at risk and other specific aspects of the dose distribution. Finally, I'd just like to note that the ethics approval for this work was done under Quality Activity 44128. So thank you to Mashid and Martin for helping organise that. And a manuscript is currently under preparation for Frontiers in Oncology. Finally, again, many thanks to Pejman and Tom for guiding me through this project and just making it possible. Without any of their help, I don't think I would have made any progress at all. Mashid for answering my various QA questions and providing access to Eclipse, again, critical to the project. Rohan White for sharing his clinical insights, Martin for his assistance with the ethics approval and insightful questions during Wednesday meetings, and all the other students and members of the UWA medical physics community for basically making a great productive work environment. Special shout out to the machine learning cluster for their coding and statistical analysis tips. Finally, here are the references for all the notes and all the studies referenced in this presentation. Thank you for listening.
Great. Thanks very much, Broderick. Well done. Excellent. Excellent presentation. Questions from Broderick? No questions. All clear. Really.
Not going to get away with it. That's really terrific work, Broderick. And I think it's going to be like a really important contribution. If you publish this, I think it'll be an important reference for people. Which means you've got to be really, I guess, sure of the process you used. Did you do any sort of sanity checks on the process, like just try shifting the whole isocentre to the left or something like that, just to see, that those distribution just followed it, or some fairly simple tests like that?
Mm-hmm. Yes, so there's sort of two key sanity checks which I sort of refer to. The first one is, yes, sort of during those initial setting up the plan of the study, I did just look at some shifts. I think I applied shifts from like 1 to 10 and saw that, yeah, definitely plan deteriorated, which was very much expected because if you got 10 times the magnitude, definitely expected. The second thing is that we also validated the splitting process to make sure that that procedure didn't affect the dose distributions too much. So from memory, I can't remember the exact numbers, but only about a 1% difference was observed when we split the plans. And that was expected because there was slight roundings used in the splitting process. But yes, there was a validation at that step as well.
Excellent. Yep.
So, yes, there's a quick question. It's really nice presentation. Thank you so much for doing this work, and thank you for Pejman, who's organizing that and inviting me for this. I think your presentation is really well organized, and you almost covered most of the stuff. I have the questions that you're saying that if you have the target less than 10 centimeter cube, this is what I think, I remember. And if it's less than 10 centimeter cube, you have this isocentre should be within 0.5. How you explain that?
Yes, so the actual mechanism behind these dose changes is very complex. It's a combination of the beams passing through different tissues, they're slightly interacting in different ways, and the overall effect changes. So it's the actual exact explanation for the changes is very hard to determine. So more data would be needed to exactly determine why those changes are happening. In terms of 0.5 millimeters, we would expect that a very small change would happen for every level of magnitude of shift, but at very small levels, these effects would be quite small in comparison to the overall dose delivered. So you wouldn't see very big changes in the metrics. Additionally, it should be noted that realistically, it's impossible to have an exact zero tolerance. Machines will vary a little bit. As mentioned, the variant acceptance of 0.5 millimeters, it's expected that machines will vary a little bit.
Yeah, the other thing is actually you said how I don't know how to put the question question to you. This is basically you're saying that the 0.5, because the machine is not, when it's rotate around this isocentre, it's not always 0.5. It's varying because it's normally for variant isocentre is elliptical. If you have noticed it, it's not like in a circular ring. So at each different angles and depend on the weighting of the dose, it will be different weighting at the different angles of during the VMAT. So have you tried to study that as well?
Yes. So
you understand what I mean?
Yeah, that's a very good point. It's a bit of a pain to pull up the slide at the moment, but yeah, when I presented those factors, yes, they were elliptical in shape, and yes, at certain points and angles, it was slightly larger than the literature tolerance, and for others, it was slightly smaller. In terms of the actual angular dependence of these effects, that was quite difficult to determine from the data, just because we're using a lot of 360-degree beams and a lot of different plans were examined. However, in a similar way to how looking at individual plans organ at risk coverage would be useful, looking at the individual angles that beams are delivered over would also be, yes, a good extension of the work done here.
Okay, thank you.
That's good. Warwick?
Great presentation, Broderick. Just a quick one. I noticed that you are using Matlab Script. At any point, did you consider other scripting languages, or what was the deciding factor in using Matlab there?
Yes, so for anyone that remembers my initial proposal, the original plan was to use an open source Matlab treatment planning system. So some work and a bit of time was sunk into getting the DICOM plans working with that Matlab open source script, but it quickly became apparent that there were some issues in using that TPS. Namely, it struggled to properly process VMAT plans as that was still in development. So yes, the selection of the script using Matlab was purely because the initial plan was to use that system, but obviously different programming languages could also be used for the DICOM manipulation.
Great, thanks very much.
Okay, thanks, Broderick. Any other questions from Broderick? Okay, Tom, great.
Oh, I just wanted to say it's not really a question, but Broderick overcame a lot of adversity trying to get this script to work, first in MATRAD and then in Eclipse. And I just want to congratulate him for working through all of those errors. I was impressed.
Thanks, Tom.
Yes, that's right. Yes, we're all impressed with the level of work Broderick has done. So I talked to in our meetings that I have a few wish lists. So one of my wish lists was to this project get Tom first started this one with VMAT, and then now with the stereotactic. This is the ultimate things. Thanks very much, Broderick, to let my wish come true.
Great. Thank you.
It's great. Great. Thanks very much. Brilliant. Stop recording now.